Hi, I'm Dr. Jay Noreen. Welcome to Health Talk. We're pleased to have with us today Dr. Laura Zimmerman from App Urgent Care Center. Dr. Zimmerman, thank you very much for being with us.
Thank you.
I'd like to start, if you would, tell us a bit about how you've gotten into medicine and how urgent care became your area of specialty.
Well, I had been at the School of Social Work at Chapel Hill. I was on the faculty there and had a very successful career there. But I just always had wanted to be a doctor and be able to do direct practice. And so I decided about 15 years ago to take the plunge. And I applied to schools and I got in. I went to medical school at Chapel Hill. And then I started residency in emergency medicine. I felt like I was too old for that, and I switched over to family practice at Pitt County Memorial Hospital. And so that was my jumping in. And having the combination, it sort of made me perfect for urgent care kind of work.
Quite a combination, social work and medicine.
Mm-hmm.
You know, that prepares you very well for being sensitive to patients, no question about that. Well, again, delighted that you're here. We really appreciate it. Could you take a minute or two and describe a bit about what is urgent care? There will be people out there who don't really know what urgent care is, and it's a relatively new concept.
Sure is. It's probably been around 20 years or so, and newer in some places. But we have a healthcare system that over the past 20 to 40 years, the technology in medicine has really moved forward, and we know much more about chronic diseases, and our generalists who used to just take care of everybody, whether it was an acute problem, they needed to be seen that day, they were able to do it. But knowing more about chronic disease, it takes much more these days to take care of those people who have chronic disease. They need to be seen a certain number of times a year and followed, people with diabetes and hypertension. And so it doesn't leave as much room for the generalist to see people who need to be seen that day. Mm-hmm. And that's where urgent care fits in. And it's on a continuum, so you have your outpatient, and then you have urgent care, which is still outpatient. It's not quite as acute as the emergency department, which is in the hospital physically and eases our ability to admit people to the hospital if they need to be admitted.
Mm-hmm. Mm-hmm. Well, App Urgent Care, of course, is part of the big Appalachian Regional Health System, which serves a large part of this part of the country. How do you fit App Urgent Care into the big system?
Well, I think we fit quite nicely. Being part of the hospital allows people to enter the system at that point in time if they don't already have a primary care physician, mm-hmm. or it allows them to be seen if their primary care physician cannot take them that day, mm-hmm. or they have acute illness or injury. And it also allows for their primary care physician to see the records that they were seen for that day. So it really allows that continuum of care. And if there's any difficulty, we can call their physician or refer them back if they can't get in to be seen and they need to be seen. Mm-hmm. We can also send people over to the hospital if they're more acutely ill and have them taken care of in the emergency department, and some of our patients need to be admitted to the hospital.
Mm-hmm. Mm-hmm. So you are clearly in connectivity with people's primary care physician, and you're able to share data and records and that sort of thing, so you have a continuum.
Absolutely, yes.
Can you talk a little more generally about how the concept of urgent care around the country has fit into the bigger system? And as you've said, it's a relatively new concept. I mean, it's not just a few years old, but it's relatively new.
Absolutely. It came out of the concept that there was really a gap in healthcare. So as chronic diseases needed more of outpatient generalist time, and we handle things that are not as acute as emergency department, there was a whole gap of people who needed to see a physician today. They had an injury, they had an illness, and they had nowhere to go. And so more and more this was seen in communities, and urgent care were born. Okay, some are part of a hospital system like App Urgent Care, and others are not. And there's different care often found in different urgent cares as well, so that's not totally been standardized, but I think there are a significant number of standardized cares that are seen there. Okay. For example, in our urgent care, we have the ability to use X-ray technology. And I can look at the X-rays, and then we have a radiologist who reads from the hospital who can also see what's going on. And we can then refer somebody to orthopedists or to physical therapy directly if need be. We have that. We have the capability of a laboratory. Okay, there are different kinds of labs that you can have. Ours has certain labs we can do right in the clinic, blood, urine, some wound kinds of things, and then some we send over to the hospital, and some specialty labs, if we feel the need, they can be sent out from the hospital system. So we have those capabilities. We have the capabilities of an EKG, so we can look at the pattern of the heart, the electrical pattern of the heart, to see if somebody needs acutely to go to the emergency department, or to get a first view if they need to go, so that can be followed up. We also see acute illnesses. So the common cold, that's our big bread and butter. We see a lot of viruses in the community, nasal congestion kinds of things, ear problems, ear pain. We get some headaches that we can keep and take a look at. We get some pneumonias, some lung diseases, coughs, things like that. We get as far as abdominal pain, things like that, we usually take the minor ones. More of the major ones need to go to the emergency department. We handle daily urinary tract infections, things like that. Sprains, broken bones, any kind of acute injury or falls, we can handle most of that. And some simple eye kinds of things, foreign bodies. If we can see the foreign body, we can take it out. Things like pink eye, we see every day.
So you really have a broad spectrum of problems you deal with, plus a broad spectrum of services, diagnostic and otherwise services as well. Now, you know, this, I should have asked you this before, but where are you actually located? I expect people out there would like to know that.
So we're on Blowing Rock Road, right down the street from the hospital. We share a parking lot with Walgreens. We're across the street from CVS, so right near the pharmacies. And it used to be an old bookstore there, but most people now know where we are. We're sort of down as you go down towards Blowing Rock.
Okay, okay. Now, I'm a 35-year-old, and I don't have a primary care physician, or at least I don't have one in Boone, or maybe I'm a student and I don't have a primary care physician in Boone. How do I decide to go to urgent care versus the emergency room? How do I make that decision? What kind of guidance can you give on that?
Well, sometimes that's easy and sometimes it's hard. Yeah. And sometimes you need that decision made once you're seen. But basically, if you feel like you need to be seen today or that day, we are open every day of the year except Thanksgiving and Christmas. We're open daytime hours, so during the week we open from 8 to 7 at night. Our doors close at 7, and on weekends we have a little shorter hours. We go from 9 to 5. And so any of those hours that can't wait for the next day, you come on in. If there are certain things, however, that need to go to the emergency department. If you're not sure, come in. We'll evaluate you. In some cases, we even know at the front desk that certain things need to go to the emergency department. For example, if someone in the family is just not acting themselves, okay, there's something acutely wrong, or they have trouble talking, or they're not understanding words, or they have weakness on one side of their body, those are concerns for a stroke, and they need to go to the emergency department. Acute chest pain, or chest pain you're not sure about, that gets worse going upstairs or exerting yourself, that should also go to the emergency department. Acute abdominal pain can be hard to assess also, just because of what technology and imaging we have versus in the emergency department, although we do have the capabilities of ordering things outpatient if it's less severe. So it would really depend on the amount of pain somebody's in.
Is it fair to say that to some degree the decision urgent care versus the emergency department is a matter of severity, do you think? Or
Absolutely.
how scary it is maybe to the non
In most
medical
cases.
person?
So the other things that need to go to the emergency department is a victim of rape would need to go to the emergency department.
For
That
legal
has to be,
reasons.
right, that has to be assessed there. But yeah, if you're in so much pain that it can't be controlled, that would be an area. We do handle back pain very well, but if there's a weakness, distinct weakness, that would need to go.
Okay, okay. Now, you mentioned that there's communication with physicians in the region, the patient's primary care physician or other specialists or whatever. How do you manage the medical records part of this? Obviously, that's a complicated thing, and how does
Right.
that work?
It is, and it's not perfect. You know, that's always going to be a work in progress. But we share the same medical records system as the outpatient clinic. The specialists, most of the specialists with the hospital, the generalists, and the pediatricians, okay? What is still separate for our system is the inpatient system is shared with the emergency department, and that is separate. But we have access to both.
Okay. So if anybody's been seen at the hospital here or with their physician is an attending at the hospital, you'll be able to connect all the records, basically.
We can. It's not always easy, but
Yes.
yes, we can look them up if need be. If somebody comes to us and say, hey, I was in the hospital, can you check on this? We do that. And the same token, if someone's seen where we are and there's some labs that are pending, they can be seen in the emergency department and in the hospital.
Now, when people have a primary care physician and they need a referral, the primary care physician will make the referral to a specialist. How do you deal with the referral situation? How does that work?
I do them directly.
You do?
Yes, if I have an acute injury, I will refer them to an orthopedist.
Okay.
If they have a primary care and I feel like they need to be seen by their primary care because of their chronic illness or just to make sure they're followed up for pneumonia or something like that, I will refer back. Sometimes I make a phone call to make sure they can get in, because sometimes it's difficult to get in.
Yeah.
And I also will refer to the wound care center for wound care instead of having to go back to the primary care. Physical therapy, occupational therapy, those I can directly do. I will do almost any that I can that's locally within town. We have a number of patients that come from out of town here on vacation, and some of them will get injured on the ski lifts. I really don't feel like I can refer to an orthopedist, you know, that lives 3 hours away from here.
Yeah, yeah, yeah. But one of the things that strikes me, and correct me about this if I'm wrong, if I'm a person that has a primary care physician and I want to make an appointment because I've got something I'm concerned about, oftentimes you don't get that overnight.
No.
It may be a week, it may be 10 days if it's not a real emergency.
It may be 3 months.
And it may be 3 months, exactly the case. So you're really, it seems you're really filling a gap, even for people who have a primary care physician just down the street, because of that access, timing access. Is that a reasonable characterization?
Absolutely. In fact, when physicians retire and their caseload needs to go to other physicians, which has just happened. We had 2 retirees in the past month, and patients cannot get their medicines refilled. Most of them we will do. There are a few here and there that we won't do.
Now, do you also serve employers who have occupational health kinds of issues? Is that one of your access points or not?
Yes, we do now. We are going to be increasing that in the future. We're bringing on 2 more providers because our loads have been increasing. And so right now we do DOT exams or commercial driver's licenses. We do just typical health exams. Some kids need them for sports physicals. Some people need them for work. It just depends on what's required in there. If it's all under the auspices of what a physician can do, we will do them. We'll take a look at what's needed and make those decisions. Sometimes it's just labs and things like that. But we are going to be able to take appointments, which we haven't been doing. It's been a walk-in basis. We also do drug screens, and we do alcohol screens for numerous companies, and do organized physical exams. We're going to be doing more of that, as well as some audiometry, and I believe we're going to be doing pulmonary function testing too.
Now, when you say you're going to be starting to make appointments, do you mean for businesses, or do you mean that for everybody?
No, I believe just for businesses to start,
businesses.
because what will happen with the businesses is, especially for like DOTs, they have a whole group of drivers, and right now 5 people will come in at once and they'll have to wait in line. Well,
Sure.
if we can schedule those every 20 minutes or every half hour, and they know when they need to come, that will keep them away from work
For an
less
employer,
time.
that becomes
Right.
very important, so
Absolutely.
everybody's not gone at the same time.
Yeah, I don't think we can do it for everybody, although that's not out of the question,
Yeah.
and we'll be deciding
But
that as
now
time
it's
goes
really
on.
walk-in for the individual.
It's walk-in.
Individual patient.
And it is difficult. First thing in the morning, with 9 people come in,
Sure.
some of them are waiting 2 or 3 hours
Sure.
just because there's only 1 or 2 people on board.
Now, you know, if you're a young family with a 4-year-old, and you're thinking, you know, he or she needs to be seen, and we really can't get into the pediatrician here in the next 4 hours, but we're worried. How do you handle children? How much of your patients are children, and how do you deal with, you know, kids are really scared by these environments. How do you deal with that?
Well, as a family physician, we were brought up birthing babies,
Yes.
and we see the whole continuum of care. At App Urgent, we see 4 months old and above, and we see many children, especially when the pediatricians are closed. In this town, the pediatricians are marvelous, and even through Saturdays, they will see most of their kids. But visitors, we see a number of kids, and if they can't get in, we are always there. We see a lot of strep throat, we see a lot of viruses, and kids are uncomfortable.
Yeah,
No.
yeah, it's scary.
We want to
It's
make
scary.
them as comfortable as we can, and that's important.
Well, you have pretty long coverage hours, as you said, 8 to 7, and during the week. What's your staff size? You have to have a fair number of staff to cover that number of hours every day.
Yes, we do. We will always have a radiology technician on board. We also have a nurse on board almost all the time, as well as at least 1 physician. At some points, we may just have advanced practitioners, but we try and have a physician on all hours we're open.
Well, I'm glad to hear what your discussion about kids, because, you know, as a young family with a little kid, you know how much people are worried about that sort
Sure,
of thing.
absolutely.
And to be sensitive to that is very, very important. I expect that you also see some App State students. Is that the case, or do they find their way elsewhere?
Well, no, we do see a number of them, surprisingly. I guess there's a lot that live off campus, and it's a lot easier for them to come see us. After hours, we see a lot of students. We see a lot on the weekends, you know, with the acute illnesses.
The question sort of unrelated to that directly, but somewhat indirectly. Do App State students in health areas get a chance to come and shadow you, or get an idea about how urgent care works?
Absolutely. Last semester, I had, I think, a whole class of athletic trainers who came and spent 3 hours at a time. We have 2 interns who are planning to be physician's assistants and apply for school that will be joining us this spring. We have nursing students that they spend, I think, 1 day or a few days a week there. So we have a number of students that come through just to observe or even help out. Many of them are certified nurse assistants, and we'll get them involved if they want to be.
Well, and the physician assistant program is, of course, brand new at
Yes.
App. And so I bet that's a great experience for them.
And a lot are interested in staying here.
Yes, I expect. It's, well, here is a wonderful place. What attracted you to Boone?
Well, I've always liked the mountains, and when I was coming out of school, I came up here and interviewed, and really loved it. I love the people here. There's a friendly atmosphere that I just had not seen before, and it really attracted me. I actually came and left and came back because I missed it. I had opened App Urgent when it started 4 years ago, a little over 4 years ago, and I left because I'm originally from the Triangle, and there was an urgent care right near us, and I just missed it up here, and so came back up.
What about pre-med students? I know there are a lot of pre-med students at App State. Do you have a chance to interact with pre-med students at all?
I have not yet, but some of the PA students are not sure if they're going to be medical, and I'm open to it, as long as there's room in my schedule.
Yeah.
But some days there's somebody there every day, so it just depends.
Yeah. Well, I expect that they would really appreciate that experience. It's quite a unique experience.
It's a great experience for pre-med or pre-healthcare because we get such a wide range, and it gives them an opportunity to see who are the people who are sick and need to go to the hospital, and who are the people who are sick but they can go home. And there's that's a real defining sort of moment for a doctor to be able to make those decisions and to be able to learn that as a student. Who looks good, who doesn't look good.
Well, since you started out in social work, you probably had some opportunity to get an idea of what medicine was really like before you made your decision. So you can probably relate to that quite directly.
Well, somewhat, yes. Yeah. I also have a background in health and physical education, and my father was a veterinarian, so I do have come out of the medical field from that aspect, more of cats and dogs. But.
Yeah, very interesting, very interesting. You know, one of the things that people talk about a lot in healthcare is cost. How can you describe how, for a patient who's coming to urgent care versus going to their primary care physician or going to the emergency department, is there any cost issue there, any cost differential or insurance coverage or any of those things?
Absolutely. We are a lot less expensive than the emergency department. And I think people might see that if they have insurance from the copay side. But that's not the whole truth. We're also more expensive than primary care. We have a number of people who don't have primary care physicians and they want to use us as their primary care. It doesn't make much difference to them if they're insured, and they would rather do that. And they really have to understand that it's less expensive to see a primary care physician, get regular follow-ups, that we don't do all the things that are done in primary care, and we just have a different set of standards for what we do. And I try and help them out with that and refer them over. Even if it takes a few months to get in, I think in the end, you know, especially when they start getting chronic illnesses.
Yeah. So your first point of access, but nonetheless, you connect with the primary care physician if and when there's a need for follow-up, or the specialty physician if that's necessary.
Absolutely. It's really important for me to know who are the new physicians in town and are taking new patients too, because a lot of generalists have full loads and can't take new people.
Sure. I didn't ask you this earlier, but what's the history of App Urgent Care Center? When did it start, and how long has it been in operation?
It started 4 years ago, a little over 4 years ago, in December of 2011. And we were first located in a different location under where the family practice is, and then we opened in this location of May of 2012, and this is where we've been ever since.
Okay. How many other urgent care centers are there around the region? Are there very many?
No, there's FastMed that's over on 105.
Okay.
And they're all over. They're a chain in many states in the United States. And then I believe there's a new one opening in Blowing Rock.
Oh, okay.
In another month or so.
Okay.
But we're the only other one.
You're connected with the whole system, so that's
Absolutely.
That's an element of what you do.
Yes.
Well, this is I think an area of the healthcare system that has emerged in a way that is sensitive to the needs of patients, is one way I would put it. Does that make some sense to you? People need it, and they need it now, and they can't get it unless they go, used to be, emergency department, or if I can get into my physician. And this is something where the response is now without having to go to an emergency department.
Absolutely, absolutely. Some people, we see people who wait a few days, a few weeks, sometimes a few months, and I've had people who have problems for a few years, and what we do is we get them to where they need to be, or we send them home.
Well, you know, even as a physician, and you as a physician, I'm sure you've even had that experience.
Oh, yes, absolutely.
There are times when I will call in a chit and call up a friendly physician friend of mine and get in early, and there's something not fair about that
Right,
in many
absolutely.
ways. Well, thank you very much. This is delightful. Thank you for coming.
Well, thanks for having me.
And we'll find another time, and we'll follow this up even more in the future.
Great. This was wonderful.
Nice to have you here. Thanks very much.
Thanks for inviting me.
Well, that's another episode of Health Talk. Thank you all for tuning in, and we will see you again next time on Health Talk.